Our final speaker for the day is Dr. Simon Grof. He'll be talking about promoting partnerships between providers and general practitioners in residential aged care, a clinical governance approach to chemical restraint. Let me tell you about Simon's background. He's a medical specialist, a geriatrician by trade, and the inaugural Chief Medical Officer at Jewish Care Victoria. His role provides strong medical leadership at both the governance and operational level, and partners with GPs who visit their residential aged care homes. He has also been working as a consultant geriatrician with Eastern Health since 2014 and is the clinical director of their Care at Home program. He is passionate about quality, safety and person-centred care and is heavily involved in medical education and clinical supervision of junior doctors. Please join me in welcoming him here.
Thank you for that really warm introduction. I'd like to introduce you to Lily. Lily is an 84-year-old lady who's been living in residential aged care for approximately 9 months. She volunteered for many years at the op shop, and cooking was her real hobby throughout her entire life. As mentioned, she moved into residential aged care about 9 months ago in the context of losing her husband to a long battle with cancer. Like other residents in residential aged care, Lily had many medical conditions, including Alzheimer's disease dementia. She had dementia with these challenging behaviours, but over the last 9 months, they were being managed pretty conservatively and supported through a behaviour support plan with engagement of Lily, engagement of her substitute decision maker, engagement of the aged care staff and her general practitioners as well. So no medications were needed over the 9 months. Things were getting a little bit worse over the last few weeks, and on one particular weekend, there was a high degree of agency staff. I think you know where this is going. They couldn't manage, unfortunately, Lily's escalating behaviours, and she was subsequently sent to the local emergency department. We'll return to Lily's story shortly. So really, I want to get across 3 areas of discussion, 3 areas to talk about. I'll give you a bit of an overview about psychotropic medications, number 1. Number 2, to discuss with you about clinical governance in relation to chemical restraints and how I understand it. And finally, the importance of fostering collaboration and communication between aged care providers and general practitioners. And I utilise general practitioners because they're really still the mainstay of the medical support in our residential aged care homes. But we know there are nurse practitioners and some other models of care as well. And this talk is all based on an article published last year in the Australian Health Law Bulletin that I co-authored with a colleague of mine, Dr. Melanie Tan, who's also a doctor and actually a lawyer and has a huge involvement in clinical governance. And this paper was called Chemical Restraint in Residential Aged Care, Clinical Governance and General Practitioner Engagement. So let's get to the talk and a bit of an overview about psychotropic medication, the number 1 thing I wanted to get across today. So what's considered to be a psychotropic medication? The Commission takes quite a broad approach when defining psychotropic medication, being any drug capable of affecting the mind, emotions, and behaviour. Thereby, the list of psychotropic medications can be quite wide-ranging, but I really want to focus on the 3 main types, and as a geriatrician, this is really, I think, where the money is. Number 1 being antipsychotics, where risperidone is, I suppose, a good example of an antipsychotic. Secondly, the anxiolytics and hypnotics, the benzodiazepines that we know about as well, our temazepams, oxazepams, and other sleepers. And thirdly, the antidepressants as well, and there are numerous antidepressants out there. I'm not going to talk about some of the anticonvulsants or the specific anti-dementia or opioid medications. However, with this broad definition, these tablets can also be considered a psychotropic medication. So when is a psychotropic a chemical restraint? Well, the Quality of Care Principles in 2014 defined a chemical restraint as a practice or intervention when they use an actual medication, and a medication is used for the primary purpose of influencing a care recipient's behaviour. When is a psychotropic not a chemical restraint? And the quality of principles once again says it doesn't include the use of a medication which is specifically prescribed for a diagnosed mental disorder or a physical illness or a physical condition or end-of-life care for the care recipient. And why is this important? We know, and the Royal Commission told us, that psychotropic medications are being prescribed lots in our residential aged care homes. A study from 2019 looked at just under 12,000 aged care residents and found that nearly 2/3 of them were on regular psychotropics, with our antidepressants being the main class. More than 30% were on PRN or as-required benzodiazepines, such as temazepam or other sleeper-related medications. And over 11% of these residents were also on antipsychotic medications, such as risperidone that we highlighted before. And we know there's good evidence now through a wide range of different resources that psychotropics should only be prescribed after medical assessment of their specific symptoms for the resident and when individualised non-pharmacological strategies alone have not succeeded. And I'd like to point out now that a really great, I think, clinical practice guideline that actually was released just a couple of months ago in May. And this new clinical practice guideline talks about the appropriate use of psychotropic medications in people living with dementia in residential aged care homes. They divide up into really easy to follow chapters for providers, for consumers, with fact sheets available. They give an overview on the three main types of psychotropics, being the antipsychotics, and as I mentioned before, risperidone being one of them as a good example, an overview on benzodiazepines, such as our temazepam, and also an overview on antidepressants. And with these three psychotropic classes, they talk about and give advice on initiating treatment, monitoring treatments, and even more importantly, discontinuing treatment as well. And there's also a separate chapter on as-required medications as well, the PRN medications. So I highly recommend you have a look at this. So I just want to go and talk a little bit about clinical governance in relation to chemical restraints. At table number 5, the champion table, we talked about quality and safety and the importance about that. And I want to get across my understanding. In the paper that I co-authored, we tried to define clinical governance. And this is what we came up with. There are numerous different definitions, but I quite like this definition because it's simple and I'm quite a simple person. So how do we control, regulate, direct, or oversee the assessment of management of a person's health to support their optimal outcomes, where the concept of health is broad and where outcomes encompasses the person's experience? And in the context of situations where restrictive practices might be used, such as giving medications for our residents with dementia with our BPSD or behaviour and psychological symptoms of dementia, I think clinical governance is therefore about how can we manage a person's physical health and psychological well-being to support their optimal experience of care. There are numerous clinical governance frameworks, and I quite like this clinical governance framework that my provider, Jewish Care Victoria, uses, and I know the Commission has spoken about this as well. You're not going to be able to see the detail, but essentially sets out 6 different domains: leadership and culture, workforce, communication, relationships. But ultimately, what I ask our staff and what I ask our general practitioners as well is, how do we know that we are achieving safe, effective, personal and coordinated care every interaction and every time for the people who we're there to actually serve, which is our residents? And it's really not just about compliance. We've heard today that quality, safety is so much more than compliance, and that's really important. Within the clinical governance framework as well, there are two other factors that, once again, I talk about with our staff and our general practitioners that really help. So one being informed consent and the other being documentation. So in respect to psychotropic medications and chemical restraint from an informed consent lens, let's say, we need to be able to provide accurate and relevant information on the proposed medication that's going to be used for, once again, the primary purpose of influencing someone's behaviour. And it's not necessarily just the doctors or the GPs that are going to be involved in this conversation. It's a real team approach. We're going to no doubt involve the person who's going to be prescribed the medication. So Lily, let's say an example, the substitute decision maker if relevant, the pharmacist potentially. We know that on-site pharmacists are potentially coming from July the 1st, and also the aged care providers and staff. So it really is a holistic approach to this. We need to discuss with any new medication the possible adverse events, and we also need to discuss the target symptoms, meaning what are the specific symptoms that this psychotropic medication is actually wanting to improve. This needs to be measured and monitored, and a data review also needs to be discussed as well. And in regards to documentation and, I suppose, the duty of care as well, what do I speak about with GPs? I speak about that thorough documentation is best practice, and it thereby supports effective communication, continuity of care, and promotes medication safety. Therefore, it is so essential to clinical governance. But with everything in residential aged care, things aren't easy, and there are lots of barriers to documentation. I've just kind of thought about a few. Number one, it's a big administrative burden. GPs tell me that why would I be documenting so many different systems? And we spoke in the technology and aged care space about the interoperability and stuff like that. But if there is a psychotropic, and then it's a chemical restraint, which is a legislative requirement to document, the medical practitioner, the nurse practitioner, they may have to document a specific form that's put in front of them by the aged care providers. They then might have to document in the aged care provider's actual system, potentially in their electronic medication management system as well. And then when they go back to their own clinic, they probably have to document in their own system as well. So this dual documentation is an absolute waste. And I think there is a lot of waste in general in health and residential aged care as well. We're trying to improve it, but I think we've still got a bit of a way to go. GPs talk about remuneration limitations as well, whereas they get primarily paid for clinical and patient-facing type jobs and tasks, and they see, rightly or wrongly, that this documentation is not a patient-facing task, and it's just administration, bureaucracy gone mad. That's what they say. And finally, they also talk about a broad definition of psychotropic medication. And we heard before, any drug capable of affecting the mind, the emotions, and the behaviour. And I'm part of a Facebook group with Doctors in Aged Care, which has nearly 3,000 medical people and nurse practitioners as well. And they talk about all things in residential aged care. And there was something that came up the other day talking about how a GP needed to document that when they were prescribing an anti-nausea tablet, which is quite common, Maxilon, they had to document and say that it actually wasn't a chemical restraint. And all the GPs were coming together and saying no one in their right mind would be prescribing Maxilon to primarily affect someone's behaviour. These are some of the barriers. It's not all doom and gloom, I promise you. Let's get back to Lily. I love Lily. So we last left Lily, who was our 84-year-old lady who'd been in residential aged care for 9 months. She had a diagnosis of Alzheimer's disease dementia, but was being managed conservatively through the support and collaboration of many stakeholders, though. One particular weekend, a high proportion of agency staff and Lily was unfortunately sent to the emergency department because they were overwhelmed. And we know this does happen commonly, even with our best support plans, documentation and the like. Lily thankfully returned back to the residential aged care only after a few hours of sitting in the emergency department, which was great. She was seen by a really good team of young doctors and nurses who ruled out a delirium, and there was no reversibility, i.e. no infection, nothing else that could be causing her worsening behaviours that had got worse in the last couple of weeks. The plan was for ongoing monitoring and management of how they diagnosed her behaviour and psychological symptoms of dementia, or BPSD, and the medication risperidone was actually charted, and this was one of our antipsychotics. This was on the Saturday. On Tuesday, when the GP rocked up for their usual rounds, there was reasonably heated discussion between this general practitioner and the aged care staff as to whether this medication, risperidone, was an actual restrictive practice, and therefore did it actually meet and need the documentation due to the legislative requirements that a chemical restraint actually is. So I was asked to get involved, which I was more than happy to do. And I pointed out quite a few different resources. The first one I pointed out was the Commission's own frequently asked questions, where one question actually is quite pointedly addresses, do behaviour and psychological symptoms of dementia, BPSD, fall under a diagnosed mental disorder? Because we heard before that a diagnosed mental disorder doesn't classify us as a chemical restraint. But the answer is quite clear, no. Any medications prescribed to treat behaviour and psychological symptoms of dementia are a chemical restraint, and thereby the requirements for the use of restrictive practices apply. So this was part of the discussion between the GP and the aged care, our aged care team. And I also pointed out to a couple of other really good resources. I showed the GP their own actual aged care clinical guide, which is kind of their Bible, also known as the Silver Book. And this talks about common things and common themes, i.e. non-pharmacological approaches as the mainstay of treatment for BPSD, the need to de-escalate, all these things that we've spoken about before. And I also showed them a recently new clinical care standard that speaks about psychotropic medicines in cognitive disability or impairments. And that gives us some high-level themes that, once again, we've spoken about before. We're prioritising non-pharmacological medication, we're only using the medicines where there's a clear reason, etc., etc. So with all this discussion, a decision was made because risperidone had been started to continue it. It was characterised as a chemical restraint, but it was going to be reviewed pretty shortly. And pleasingly, after a couple of weeks, this medication was ceased, as it wasn't targeting and it wasn't actually doing anything about the target symptoms that we wanted to approach, and Lily was actually having some adverse effects because of it. What else did we do? The aged care staff, in collaboration with Lily, her substitute decision maker, and the GP, also updated her behaviour support plan. And then we made sure that documentation was quite clear as we could. So in the future, on a weekend, if there is a high degree of agency staff and Lily's behaviours do escalate, then as per Lily's wishes, she's kept it at her home for as long as possible. And I thought that was a pretty good outcome. So I've talked about the first two. The last area I just wanted to touch upon was the importance of collaboration and communication between GPs and aged care providers. And like I said before, I use GPs, but we could easily extrapolate this to nurse practitioners or other people. I'm once again showing you our clinical governance framework, and I want to put a bit of a different spin on it, particularly two domains that probably don't get the love or the involvement of some of the other domains, that being communication and relationships and also effective workforce. So from a communication and relationships point of view, what do I hear from GPs? And once again, GPs that I work with through Jewish Care Victoria, and also the ones, doctors in aged care, a big proportion. They tell me and they tell each other that they don't get any information. They don't get spoken to by the Commission at all. And a lot of the information that comes to them is about, you need to do this, you need to do that, you need to sign this form. And they're pretty disengaged, to be honest. And the question I ask you is, how do you communicate to your GPs or nurse practitioners? Because the vast majority of residential aged care homes, they don't employ the GPs. They don't credential them. They don't pay them. So GPs are really, they have a direct relationship with their patient, the resident themselves. It's a big topic that the Royal Commission didn't really tackle at all. What do? I try and partner with our GPs. That's one of my main roles. And I also partner with some of the other visiting practitioners as well, such as our geriatricians and other medical specialists, and our pharmacists, because ultimately we're all here for the same reason, to provide good resident, good patient care, ultimately. In regards to my tasks, I'm at Jewish Care Victoria for 2 days a week, and the other 3 days a week I'm working clinically in the hospital setting. At Jewish Care, I'm part of the executive leadership team, overseeing residential aged care and home care as well. And I try and write to our GPs on a monthly basis to talk about our local provider type issues, but also outline to them in easy language some of the clinical-wide high enterprise risks that they don't really hear about. And they tell me their college, the Royal Australian College of Physicians, doesn't really have a big focus on aged care either. I'm heavily embedded in our clinical governance team and chair our medication advisory committee, and also chair our serious incident review committee, looking at serious incidents and how we can foster that continuous improvement within clinical governance. And I'm also heavily involved in education and training for our GPs, but also our staff. The second domain I wanted to touch about was a bit about effective workforce. It's a bit of a different spin to what this framework was primarily done for, but just to talk about, we've heard about the staffing workforce issues throughout the day, and that is no doubt so important, with a high proportion of agency staff, burnout, turnover, all that type of stuff. But I wanted to just put a different lens on that from a GP point of view. Every year, the Royal Australian College of GP puts out a Health of the Nation report. And I've got some statistics from 2023 where they sampled GPs throughout Australia. This isn't actually about GPs in aged care, but I personally think these stats are probably worse than aged care. And what did they find from the GPs in Australia? They found that nearly 30% of GPs in Australia plan to retire in the next 5 years. They found a quite clear downtrend in job satisfaction and quite a high burnout rate as well. And with GPs who actually have their own registrars and trainees, only 4 out of 10 actually recommended being a GP as a career. That's astounding. Every trainee and medical student and allied health student that works with me on the wards at Eastern Health or that I see in Jewish Care, I love being a geriatrician. I love it. Like, I'm selling that all the time. I think it's the best job in the world, but GPs 4 in 10, that's really damning, I think. So we need to look at creative ways to, I suppose, help go into this going forward, whether that is more training, whether it's medical student training, nursing training, allied health training in the residential aged care setting, in the home care setting, just to get our young, enthusiastic people involved in aged care. And we need to explore alternative models of care, whether that is nurse practitioner-led, whether that is virtual health, telehealth. And these problems are compounded much worse in rural and remote type settings. So I think we've got a little bit of work to do, but there is a lot of goodwill, I think, going forward. So in summary, I hope I got across to you these 3 points. Firstly, a bit of an overview about psychotropic medications, telling you what is a chemical restraint, what isn't a chemical restraint, and why it's important. Secondly, telling you about how I understand clinical governance, and what I want to get across to my team is, how do we know we're answering the important question that we're providing safe, effective, personal and coordinated care every interaction, every time, because ultimately we're servicing and we're there for our people, our residents primarily. And thirdly, how do we go about fostering collaboration and communication between our practitioners and our aged care providers as well? Thank you for the opportunity. Happy to answer questions now or at networking drinks. Thank you.
Is there any question from the audience for Dr. Simon Grof?
Come and find me. Happy to chat. A bit easier over a drink, I think so. And thank you for being here. It's hard prior to networking drinks to be here. Thank you for your attention.
Thank you, Dr. Grof. And